Well, hello everybody and welcome to this episode of GU Cast. For those of you watching on YouTube, I'm not joined as ever by my fabulous co-host Renew Eapen. I'm joined by friend of the podcast, Andrew Weickhardt. Andrew, thanks for popping back in.
Thanks so much for having me back.
It's great to see you. So Andrew is a GU medical oncologist here in Melbourne. He works at Austin Health and the Olivia Newton-John Cancer Institute. Well-known friend of the podcast. We've had you on before. And we're having you back on this time, and we'll have our other guests joining in a moment because of this big update that we heard from a very important trial that we've been looking forward to, the ENZA-P trial update that Louise has read out in San Francisco today.
Fantastic news.
It's great news. So that's what we're going to talk about, the ENZA-P trial. And we'll be joined by Louise Emmett, who presented this data today at ASCO GU and also published in Lancet Oncology simultaneously. So this is a big deal in GU medical oncology. And also this podcast is supported by two of our partners here on the podcast, our silver partners Novartis, who of course have an interest in radioligand therapy, and our gold partners Astellas, who have, of course, enzalutamide, AR pathway inhibitor across the spectrum in hormone-sensitive prostate cancer. But shall we go and track down Renew, because she is on the podcast, but just not here in person. So here she is on the screen, and also Louise Emmett. So I know Louise is in San Francisco. She just stepped off the stage over there and has been kindly joining us. We'll come to you in a second, Louise, and introduce you properly. But Renew, thank you for dialing in. Now, where are you and what are you up to?
I feel like I should be saying hello, Declan and Renew, but I'm not there. Andrew, you look good in my seat, but I do want it back in a week or so. So yeah, I'm in India. I should be in San Francisco for ASCO GU, and I would have caught that fantastic talk by Louise, but I am in India for a few things. But I've got this looming PhD completion date coming up in a couple of weeks. So it turns out I had to get out of the country to get some work done.
That's too many distractions in Melbourne. We all know that. But it was very good of you to stay committed to GU Cast and join us for this. And of course, your PhD is in the field of radioligand therapy, and maybe we'll talk a little bit about that later. But Louise Emmett, thank you for joining us. Another great friend of the podcast, Andrew. You've heard her on this podcast many times over the past 5 years, I'm sure. Louise is nuclear medicine physician at St. Vincent's in Sydney, has been very, very involved in PSMA imaging and radioligand therapy, of course, for many years now. And she's PI on this trial, the ENZA-P trial. So Louise, welcome and thank you very much for joining us.
Oh, thanks so much for having me. It's a great pleasure to be able to talk about ENZA-P.
Okay, so ENZA-P, we're going to come back to you in a few moments to talk specifically about the updated data that you presented and you co-published today. But before we do, Andrew, we thought we'd just come back a little bit for the audience out there who maybe don't know anything about ENZA-P. It seems familiar to us, having been supporting the trial, and we're not investigators, but we did send patients to you and to our colleagues at Peter Mac on this. So tell us a bit about ENZA-P, about what it was. What sort of patient population roughly were you looking at? Because you are an author on the trial, and what were the allocation arms, the treatment arms?
Yeah, thanks, Declan. I mean, this was a great cooperative group trial led by ANZUP and Louise's intellectual endeavours. And this study looked at the role of lutetium in the metastatic castrate prostate setting in patients that hadn't yet received chemotherapy. And these are patients who had progressed on androgen deprivation therapy, who had the indication for commencing an androgen receptor pathway inhibitor such as enzalutamide. And the question asked here was, in patients who are due to commence enzalutamide as first-line setting in that CRPC setting, who hadn't yet had chemotherapy such as docetaxel or cabazitaxel, what was the benefit of adding lutetium-based therapy to that cohort? And specifically, the ENZA-P population was really a patient population taken from trials such as PREVAIL, where we looked at patients who are at intermediate or high risk for doing poorly with enzalutamide. So we've seen these patients before in clinic. If we go back some years when we were using enzalutamide and abiraterone and other pathway inhibitors in this patient population group, it's those patients that progressed more quickly that we thought, could we do something better in combination with that pathway inhibition? So specifically factors such as patients who had presented with widespread metastatic disease, de novo metastatic disease, patients who had opiates for pain relief, high LDH or ALP, and a number of other risk factors for progression. And these were patients who had 2 or more risk factors for early progression on enzalutamide. And ENZA-P studied the role of enzalutamide alone or enzalutamide with lutetium. And Louise's thoughts on this were that lutetium could be used with an adaptive dosing. So unlike...
what does that mean? Because we hear about it a lot. And I remember when the initial paper came out, a lot of people were very intrigued by this adaptive dosing. So just remind us, what is adaptive dosing? Or we'll have to pick Louise's brain about it.
So I'm a simple medical oncologist. Yes. So I'm going to give you my take on it. I mean, I think,
dumb it down to the urology level as well, if you don't mind.
I mean, if we have a look at how lutetium-based therapy has been used in the chemotherapy experienced population in a trial such as therapy, patients are selected for therapy with lutetium based on PSMA expression, and there's a number of different ways to select patients, but roughly speaking, you look at the scan, does it glow like a Christmas tree? You would expect that lutetium-based therapy is going to target and release in the right area. Patients receive treatment every 6 weeks with lutetium-based therapy. If they are responding to treatment, you continue to treat them. In adaptive-based treatment, here patients receive 2 cycles of lutetium given 6 weeks apart. A repeat PSMA PET scan is done, and looking at the intensity of uptake on that restaging scan guides whether or not patients would proceed with treatment. And I think this is driven out of the knowledge that when you do give patients lutetium, some patients respond so well that you see hardly any PSMA expression on that follow-up scan. And therefore, you can make a sound hypothesis that, in fact, further PSMA-based therapy at that time point is wasted therapy because you are not actually targeting any cells with high expression. So patients who had had a good response, I guess we might hypothesize that those patients that had had a complete reduction in PSMA expression, those patients were just given 2 cycles and observed with the possibility of retreatment in the future. Patients who had had an incomplete response or reduction in PSMA expression went on to receive 4 cycles in total. And I think this is a rational-based way of treating patients that might spare them toxicity. And when you consider the cost of lutetium, it might spare financial toxicity to the healthcare system as well.
Absolutely fantastic. So Renu, over to you.
Yeah, it's very exciting, isn't it, Declan and Andrew? And I've got to say that one of my favorite things about this is that, of all the podcasts we do, I love completing the trio of a high-profile presentation, co-publication in a major journal, and now a podcast. So Louise, congratulations. You've just stepped off the stage to great reception. ENZA-P, such a fantastic trial. Can you take us through some of the main highlights of the trial and the new findings?
Yeah, sure. So, I think this is really, this presentation and this publication is about the secondary endpoints of the trial. We've already published the primary endpoint, which was PSA progression-free survival, and there was a 5-month difference in progression-free survival. So the question was, what sort of difference would there be between enzalutamide plus lutetium PSMA if we're looking at overall survival? It was a secondary endpoint, and we did have quite a lot of crossover in the trial. So 38% of patients crossed over from enzalutamide alone to receive lutetium PSMA after they'd come off the trial. So it wasn't a given. But what we found was there was an 8-month survival difference between the 2 arms. So if a patient was on enzalutamide alone, there was a 26-month survival. In those patients, then enzalutamide plus 2 or 4 doses of lutetium PSMA was a 34-month overall survival. So that was statistically significant with a hazard ratio of 0.549, so really low hazard ratio for the mCRPC space. And what is also really lovely was this is a paper and a presentation where we were looking not only at survival, but also health-related quality of life. So we looked at deterioration-free survival for physical function and for overall health-related quality of life. And then we also looked at health-related quality of life for fatigue and pain. And in all of those instances, there was less pain, less fatigue, less physical function problems, and improved overall health-related quality of life for the combination. So I think it's fantastic. Improved overall survival, improved progression-free survival, and improved outcomes for patients in terms of quality of life.
Really
Yeah.
amazing. Yeah, it's amazing,
Yeah.
Louise. I mean, it's one of those things where and I find this, especially as we bring these treatments further and further forward in the disease spectrum of prostate cancer. I'm always reassured by the fact that lutetium PSMA seems to be so well tolerated, and it's a relief to see that, especially as we bring it forward in the treatment setting and you're giving it more, further upfront.
Yeah. I totally agree. One of the other things I really liked in the trial, and I perhaps hadn't expected, a little bit overall, like the overall survival hadn't entirely expected to see, was the lack of toxicity at a hematologic level. So, if you ask anyone what's the toxicity from lutetium PSMA, they say hematologic. Everyone gets anemic, everyone gets thrombocythemic. But in the ENZA-P trial with this adaptive dosing of 2 or 4 doses, 4% of patients had grade 3 anemia, and 1% of patients had grade 3 thrombocythemia. No patients had grade 4 or 5. So an incredibly low rate of hematologic toxicity using this adaptive dosing model. And I think that's really exciting for how we should treat patients in the future.
Let's just talk about adaptive dosing for a minute. And we just heard Andrew talk about it before, but ENZA-P is one of the first trials to really utilize it. And it makes sense because you are using an imaging modality where you really can see what you're treating. And you're definitely taking that to its full advantage.
Yeah, so I would say it's not just the imaging itself. We're seeing what we're treating, but we're also using the PSA. So it's a composite biomarker guided treatments. We're using the drop in PSA plus the drop in volume to identify highly radiation sensitive clonal populations that we don't need to keep hitting. And so because we're treating more than one clonal population, we're treating a PSMA-sensitive population, and we're treating an androgen receptor-sensitive population. They're probably slightly different. We get to very, very low levels of residual disease within the within the combination of this trial, which is really exciting to see. And I think I'd love to see what we can do in the future to actually maximize that in other disease states.
Absolutely. Declan and Andrew, back over to you. Really exciting results with some great implications for patients.
Yeah, thanks very much, and congratulations again, Louise, to you and all your investigators and so on. I know you want to acknowledge them as well later on. But Andrew, I suppose a lot of people will be approaching us about this. There's a lot of attention, a lot of social media, news reports, etc. But it's a phase 2 trial. This is not like a pivotal registration trial, but nonetheless, such a big overall survival benefit with such amazing tolerability, bearing in mind you're adding in a whole extra thing, Okay, enzalutamide, ARPs, they're very well tolerated, but still you think you add in a whole extra thing that's improving survival. You'd expect there'd be a cost in terms of quality of life, but there isn't. And adding it into the ENZA is really beneficial. But what's your take as a very experienced trialist on a phase 2 trial like this? Will it change? Can it change practice when patients come to us now and say, Can I have it? I mean, I'm exactly like this. My dad's exactly like this. He's just starting and he's got all those adverse features that mean he's highly likely to progress on an RP. Can he please have some lutetium? What'll be your response?
Yeah, I think this is a fantastic proof of concept and an amazing trial to have demonstrated how bringing the lutetium earlier into a patient's treatment journey can add so much value in terms of quality of life and overall survival improvement. But I think the caveat here is that we no longer see as commonly patients who are treated with ADT monotherapy and then sequence on in the first line to enzalutamide or a different androgen receptor pathway inhibitor. And so like Piece 3 presented last year at ESMO, and showing an overall survival benefit with the addition of radium to enzalutamide in a similar patient population. I think this trial here shows the tremendous ability to combine these medications safely with androgen receptor pathway inhibition. It shows that using adaptive dosing can spare the marrow toxicity, which might also be due to the fact that patients have not had chemotherapy before. And I think it really provides a window into how these treatments will then be trialed in large phase 3 trials in the metastatic hormone sensitive setting. And so the tremendous opportunity for using these treatments perhaps to target the clonal populations that might exist at the time of diagnosis with metastatic hormone sensitive prostate cancer, there may be an opportunity to use treatments such as lutetium in 1 or 2 doses initially, and then reviewing for response in combination with pathway inhibition with enzalutamide or your treatment of choice. And I think that's where the field is moving. And as of today, I think it would be lovely to have access for the few patients we do see if we were able to combine that. But this is an expensive treatment still anywhere in the world. And so that, more than anything else, is going to limit also our ability to use lutetium outside a trial setting in many different locations.
And while with such a good positive result from a phase 2 trial, people might, let's do a phase 3 trial. For those reasons you just mentioned, that the field has changed, that we're using enzalutamide and other AR pathway inhibitors up front. Is that then the sequence? Is it say, well, we're not going to do a phase 3 trial for what will soon be a historic population, but there's enough in this to say it's very well tolerated, adding it into a drug like enzalutamide. So the leap forward should be almost into the phase 3 trial. I know Louise wants to talk about that, but would that excite you as a GU medical oncologist?
Certainly. I think a study that's looking at the incorporation and incorporating the lessons that Louise has drawn from this into the hormone sensitive setting is where we'd like to use the treatment, because we still see patients in the hormone sensitive setting start on treatment with androgen receptor pathway inhibition with results that still disappoint us in clinic. The patient that presents on combination therapy with pain and progression within 6 to 12 months. These are patients that still exist, even though we get much better control than we used to. We need to do better in that setting.
And because, of course, the upfront PSMA trial read out just a few months ago, which is in the metastatic hormone sensitive setting, and we've featured it on the podcast. And then next year, PSMA addition, or next year, the year after, will read out. So there are ongoing trials in it. But I do think ENZA-P, because it shows such efficacy on top of an RP, I know it is a more advanced disease setting, and the tolerability means that that's probably the future. We should be now more excited again.
Right.
After, upfront is telling us something, ENZA-P is telling us something,
right.
PSMA addition.
And I think, what's interesting about this study as well, and we can ask Louise, is that, with the cooperative group study through ANZUP, we're able to collect a lot of translational work as well. And Louise might want to comment on, what implications she thinks that translational study she put together, some of which is presented in the Lancet here, has in terms of how those studies might run.
Yeah, go ahead, Louise. I mean, this is a part of the paper I think is really exciting. When we're getting these treatments, we're seeing efficacy for them earlier and earlier in the prostate cancer setting. Selection of patients and sequencing of treatments become so important, don't they? And if I've learned anything from some of the translational work that we've done for lutectomy, it's that in a lot of settings, lutetium PSMA alone won't be enough. And I really think the future of prostate cancer is going to be in combination treatments. So I'm really interested to see what you've discovered in some of the translational and biomarker work from ENZA-P.
So first of all, just listening to what Andrew and Declan were saying before about where this should go, I totally agree with the metastatic hormone sensitive space. It's a natural space to be giving adaptive dose lutetium and in combination with ARPI. And I'm a nuclear medicine physician. I can say, do we really need chemo? Is this enough? And that's something that we should really be looking at in patients with high risk disease, giving it in combination with ARPI, but also in the metastatic castrate resistant space. What about, enzalutamide? What about AR degraders with lutetium? What about second line ARPI with lutetium? So I think we have a lot of clinical work to do to figure out where we're going to be. And then, as you say, translational stuff. So ENZA-P had a huge translational component to it. We have 1,500 scans that we've quantified looking across serial PET and serial SPECT, and then we've matched that to circulating tumor cells and to ctDNA, cell-free DNA at multiple time points on the trial. So that's, now that we have mature overall survival data, all of that analysis can happen. And I'm super excited about what we're going to find in terms of how it's going to guide who we treat, what we treat, when we treat, why we should treat with what we treat, and really try and leap forward in our knowledge on improving patients' lives.
Amazing. I guess the next conversation is going to be where next?
Yeah, I mean, where next? So I think there's an enormous amount to come out of ENZA-P from a translational point of view. You're part of that, Renu, and I think that we're analysing fast and furiously to try and figure out, cell-free DNA in the therapy trial looked like a great predictor for response to lutetium PSMA. What does that mean when you add enzalutamide with that? And what does it mean, in terms of predictors for response, such as FCV mean or total tumor volume on PSMA PET? So they're all things that we need to look at. And of course, a lot of the translational stuff that as a nuke med physician I can't even understand is going to happen within the trial, and composite biomarkers, all sorts of things.
Andrew, we had a podcast we posted a few days ago. We had Oliver Sartor and Michael Hoffman here in the studio with myself and Renu, kind of future gazing in radioligand therapy. And a lot of that was spinning into, other tracers, other targets. So do you have any thoughts on that, like 5 or 10 years' time? I think it'll be very clear lutetium PSMA we'll know how well it works moving forward, but I know you've been very involved in this for years. What are the things, tracers, targets, the two things that we often talk about?
Yeah, I think Michael and Oliver are obviously well placed to be the experts and provide their opinion. I see the role here in terms of, as a medical oncologist, trying to work out how these new targets and tracers can be incorporated at different sequences, maximizing outcomes and minimizing toxicity. So as Louise has said, one of the issues with lutetium to date when we've used it in patients is marrow toxicity. So are some of the newer tracers better with the handling of the marrow? Are some of the different targets that we're looking at in prostate cancer going to be better for radioligand-based therapy at different times because of differential patterns? And I think one of the key patient populations that I think is underserviced by the therapies that we have are some of those patients with the neuroendocrine differentiation with prostate cancer. And I'm fascinated to learn how we can try and find a target with overexpression in this patient population that we could use some of this radioligand therapy to enhance outcomes, because they're the patients that are the heart sink patients, exactly. The bulky liver metastasis, rapidly growing tumours, and they respond poorly to treatment. And a PSMA PET scan will show very little uptake. They're not suitable for lutetium, and I'd love to find some of these types of treatments we could use in that group.
And even with that, as these newer tracers and targets are being developed, there are still lessons in ENZA-P around adaptive dosing, translational work, not just on tissue, but on imaging biobanks, etc. Aren't they? I think that's what's the beauty. And we want to ask Louise about how did you run this trial and these beautiful investigator-led, supported by trial groups like ANZUP trials. But isn't that part of the beauty of some of these investigator-led studies, is you can dive into sort of more granular stuff that sometimes doesn't make it into the pivotal study? Yeah,
I think it's really the ability with these cooperative group studies to have a brains trust, ask questions and generate hypotheses that are meaningful to clinicians. And I think, Louise and others that, intellectually drove this study forward were able to harness the energy within the Australian population of GU oncologists, nuclear med, urologists, and the whole community to recruit quickly for this study and try and answer a question that was vitally important to all of us.
Totally right. And I had a few patients in this study as well through Peter Mac. And Louise, we want to hand back to you in finishing about that, just to, I suppose, acknowledging this fabulous trial and the work that you put in leading it, but all the people you worked with, the patients, of course. So just can you tell us a little bit about that?
Yeah, absolutely. So there's, a huge number of people. Obviously, it takes more than a village to run a trial, and so really grateful to originally the funders of the grant were Movember and the Prostate Cancer Research Alliance, which was a federal government of Australia initiative. Also, we got institutional funding from the St Vincent's Clinic Foundation. Roy Morgan himself donated significant funds just to get the grant going, and Genesis Care was very generous in also co-institutionally funding the trial. So, enormous thanks to the funders. And then for the research side of it, it was the PCF Challenge Award that has allowed us to do a lot of the translational work in the study, and we'll be able to take it to a really high level. So incredibly grateful for that too. And then, of course, ANZUP were the sponsors of the trial, and CTC NHMRC ran the trial at 15 centres across Australia. And as you said, the patients, putting yourself on a randomised trial when you have a disease that is likely to kill you very fast is a brave thing to do. And sticking with a standard of care arm, even when you're not doing very well, I really feel for those patients. I wish I could go back and, knowing what I know now, help them more. So, all the investigators did a fantastic job at all the sites. It was really Australia pulling together in a fantastic way.
I would say, yeah, almost yet again, Andrew, we've had a nice pedigree in Australia over the past 10 years of doing very nimble trials in this area of PSMA imaging and theranostics. So take a bow to that community. Yeah. So Renew, it's a big one, isn't it? I'm sorry we're not all there in San Francisco to enjoy all the conversations about this, but I know we'll be hearing lots more, won't we, in the coming weeks and months.
Absolutely. Definitely sorry to have missed Louise's presentation, but we had her on the podcast, and what a lovely paper to read in Lancet Oncology. So huge congratulations, Louise, to you and the entire team for bringing this to fruition.
Thank you. Thanks for having me and talking about the trial. I really hope it makes a difference.
Yeah, absolutely. Very reassuring for everyone to see this data, and the tolerability is, I'm particularly impressed with this, starting drugs like enzalutamide that work very well, but being able to add in this without a toxicity thing is very important, because it's not always the theme, is it? Intensification in oncology with the goal of improving an oncological outcome often there's quite a price to pay. So I think it's very reassuring for patients in trials of radioligand therapy.
Yeah, definitely.
Wouldn't you say? Great. Well, look, that's all we have time for from Renew in India, from Louise in San Francisco, from myself and Andrew stuck here in Melbourne working. That's what we've been at work today, haven't we? So it's been really nice to be able to get together and talk about this great trial. Congratulations to everybody who's been involved, and thank you, Andrew, for dropping in.
Thank you. It's been a pleasure. Watch out, Renew.
Yeah. He was one of our.
This seat.
Yes, it's comfortable, isn't it? Yeah. I'm more worried about my seat. She'll come back and say, "Declan, I quite like Andrew on the podcast. Why don't you go over there and twiddle the knobs or whatever?"
Yeah, it would be awkward. It's your house, so we'll have to change the locks.
She's pretty feisty.
Yeah.
And the rest of the family and the dog prefer Renew to me, to be frank with you, but actually, Renew, you might remember Andrew was one of the earliest guests on GUcast, I think 5 years ago, back in 2020. I remember when we were in our...
He cycled into Peter Mac.
Yeah.
I did. Yep. And you had the very small studio at that time, and I was wearing some cycling gear, and you've gone on to bigger and better things.
Well, I'm going to try and dig out that photo. And if you're watching this on YouTube, we might flash up a picture of the very fit as ever Andrew Weickhardt cycling into the old GUcast studio. Great. So look, that's all we have time for. Thanks once again to our partners, our silver partners, Novartis, who have been key supporters, of course, of this. And it was their product, PSMA 617, that you were using in this trial, and to Astellas, of course, our gold partners supporting enzalutamide, and they've been great supporters of very many investigator-initiated studies in this country through ANZUP, including, of course, ENZA-MET and ENZA-RAD to come. So thanks very much to them for supporting us at GUcast and allowing us to talk about this great stuff. We'll be back very soon with another podcast. Thank you very much indeed.